Hello, everyone. Good morning, good evening, good afternoon. Thank you very much for joining the Global Digital Health Network meeting for this April. This is Steve Allis, the co-chair of the Global Digital Health Network, and we're very excited to have a great presentation lined up today on multi-stakeholder approach to digital health and nutrition amidst the COVID-19 response. We have 4 speakers lined up. They will speak serially. We will encourage everyone to use the chat function. We'll be taking questions from the participants during the presentations as well as at the end. So feel free to put your questions in and we'll try to get them answered as best we can. And then we'll have time for a Q&A at the end. I'd like to take a moment to introduce the speakers. We have Miriam Chang, a nutrition specialist from World Vision, and she has served as technical advisor and program management roles in World Vision Canada, World Vision International Southern Africa Regional Office, and World Vision Malawi for more than 10 years. She'll be followed by Ricardo Lampariello, who's head of health at Terre Foundation, the leading Swiss organization for children's aid, improving the lives of millions of children around the world. Then we'll move to Marlies Gorgens, a senior specialist in decision science and artificial intelligence at the World Bank. Marlies leads the Decision Data Science and Innovation Program in the World Bank's health practice and is responsible for coordinating analytics for COVID-19 across the World Bank. And then we'll move to Claudia Yush, who's the founding CEO and board member of the Cloudera Foundation based in Silicon Valley. And she was previously the Associate Vice President at Rockefeller Foundation, leading the organization's Strategic Insights Division. So with that, I'll say thank you very much, and I'll turn things over to Miriam Chang to kick us off. Thank you, Miriam.
Pleasure to have a chance to share a little bit about the Alliance for e-DIAgnostic. We call it AleDIA, and it is a collaboration amongst 3 NGOs, namely Terre, Action Against Hunger, and World Vision. And we actually started our work before the COVID-19 pandemic. In fact, we were formalized as a consortium back in 2018, and we have signed consortium MOU during the World Health Assembly. The 3 organizations share many common interests. Among these, we have improving health and nutrition outcomes for children, and we all are interested in working towards strengthening health systems and working towards universal health coverage. Over the past 20 or more years, we have seen dramatic reduction in child mortality from over 12 million under 5 mortality per year back in the 1990s down to approximately 5 million per year. And even though with this dramatic improvement, we are still seeing approximately 45% of these deaths in children related to malnutrition. I know we have a diverse audience today. Some may be coming from tech industry, others more from global health. So just bear with me for a very brief explanation that we know malnutrition and childhood infections are closely tied together. We know that malnourished children are more likely to get sick. When they do get sick, they tend to get more severe illnesses and longer duration. And for children who get infections repeatedly, they are also at higher risk to becoming malnourished and threatening their lives. So globally, we have 2 sets of treatment protocols that already exist and endorsed by UN agency and by global partners. We have the integrated management of childhood illnesses, namely IMCI, that addresses childhood infections such as diarrhea, malaria, and pneumonia. And for acute malnutrition, or we call that wasting malnutrition, we have the community-based management of acute malnutrition, namely CMM. These 2 sets of protocols were designed originally separately, but they are really meant to be implemented in a way where if a child comes into a primary healthcare facility presenting with an infection and they go through an IMCI consultation, the health workers are supposed to also follow the protocol to assess for malnutrition and address that malnutrition. Similarly, for children who present with malnutrition and show up at the CMM clinic, The health workers are also supposed to check at the outpatient level if the child has medical complications. So these are what is supposed to happen. Unfortunately, in many struggling health systems, we see a degree of siloing effect when these protocols are being implemented. In some extreme cases, you can even have the clinics implemented on different days. And when conducting an IMCI consultation, the health workers won't even have access to the necessary commodities or medicines to treat children who need to be treated for malnutrition. So the fact that these protocols are not adhered very well is a global topic. And our partner ACF can probably give a complete seminar, webinar on the various aspects of how these protocol poor adherence is leading to poor health and nutrition outcomes. And TDH, thanks to their research in partnership with the London School of Hygiene and Tropical Medicine, they've also looked at when implementing the IMCM protocol in their projects in Burkina Faso, there are different elements of nutrition tasks that need to happen during an IMCI consultation that are followed to varying degrees. And in often cases, the ready-to-use therapeutic food that is needed to treat with nutrition is either not given or the prescription is delayed, leading to poor outcomes. And there are various different aspects of protocol adherence that are a challenge in low resource setting. We know that where health workers are supposed to be counseling caregivers and of young children to adopt recommended feeding practices, that counseling may or may not happen consistently, sometimes because the health workers don't speak the same dialect as the caregivers. And we know that there are a lot of challenges when it comes to using paper registers in terms of data quality, the data completeness, and the lack of availability in a timely basis for health service managers to use that data to make decisions. So in these very challenged systems, we also have challenges around losing children to follow-up, the defaulters from the programs, and we have difficulty tracking from one level, such as community referral to health clinics, and then the counter referrals and following up with children who are discharged from a high level of care. So if that's already a big picture of challenges before COVID-19, now we have even stronger concern about the well-being of children. In fact, earlier this month, World Vision International released a report, and I've provided the link here, and you can access it. You can share the link. And looking at the potential aftershocks of COVID-19. And our fear is that the secondary health impacts, such as rising level of poverty, disturbed livelihoods, broken food security channels, will all add to more children's lives being threatened than by COVID-19 itself. The report is based on the analysis of secondary impact of Ebola crisis, learnings from that crisis from 2014 to 16 in 3 countries, and then also taking into account existing need in 24 countries prioritized by the UN Global Humanitarian Response Plan for COVID-19. And the estimate is that as many as 30 million children worldwide, actually in the 24 prioritized countries, will likely be threatened by secondary health impacts of COVID-19. And we are likely to see increased burden of malaria, decreased immunization coverage, increased malnutrition cases, and health systems being even more stretched and overwhelmed by COVID-19 patients. So as a consortium, we started working together before the pandemic, and we knew those issues with less than desired level of protocol compliance is not helping children get the best services they can get when they approach health services. And now, in view of COVID-19, this issue becomes even more augmented and become even more urgent. So as a consortium, we have learned from our individual experience and from the broader global digital health communities to realize that using technology can help improve treatment protocol adherence, so that when health workers they have an encounter with the caregivers and the young children, they can make the most and get the best out of that encounter and provide the children with timely and appropriate treatment to help them get better. And that using technology has also the potential to help us work with the health workforce to improve the capacity to respond to the health needs, to treat childhood infections that are expected to rise throughout and after the COVID-19 pandemic, and also address increase in malnutrition prevalence. And our common interests at this point focus on improving diagnostic and treatment of childhood illnesses and malnutrition by using an integrated IMCIM and CMM digital solution. We believe that by integrating these two sets of protocol using digital tools, we can improve nutrition and health outcomes, and we can contribute to health system strengthening during this time that this really needed. And as a consortium, we're not starting from scratch. In fact, we already have two standalone digital solutions addressing childhood infections and acute malnutrition. TDH has been very successful in the AleDIA project in Burkina Faso and also in Mali, deploying their IMCI mobile app called the REC. And World Vision also has experience with our CMAM mobile app in 5 countries. However, even though we have 2 good solutions, we know that health workers are often burdened by what in the digital health community we call pilotitis. There are a lot of digital solutions out there. And the last thing we want is to burden health workers who have increased workload, who are working in challenging environments with multiple apps on multiple devices feeding into different databases where the data is not together, not integrated, not helping health service managers to make decisions to improve the service. So as a consortium, as partners, we are committed to reducing fragmentation in the digital health space. So I apologize for this, this slide looking a little bit overwhelming, and most of it is in French. But the gist of it is that instead of 2 separate apps following through with 2 separate protocols separately, the consortium partners have taken quite a bit of time in consultation with our country partners in Burkina Faso, in Mali, and in other West African countries to look at what that integrated workflow would look like when you integrate IMCI and CMAM implementation. And this is basically a workflow from identifying the cases to referral, to triage, to the consultation, treatment, and follow-up when you integrate the 2 sets of protocols together at the primary healthcare level and at the hospital level. But as a consortium, we also are intending to eventually develop a digital app specifically for use by community health workers, so that that continuum of care is well supported by a suite of appropriate digital tools. So as NGOs, we know that it is tempting to just work on our own, hire a technology partner, and just come out with the digital solutions as fast as possible. Yes, that's one approach. But we know that to reduce fragmentation and to work towards scale in alignment with the global digital development principles, we really need to take that multi-stakeholder approach. And our key stakeholders, of course, include the local ministries of health. And that's why when we work together as a consortium, we always try to engage our local partners, and we are blessed that, as 3 organizations, we have existing very strong rapport with the country Ministry of Health. And together, that's just a very strong foundation to build on. As well, we need our research partners to help us look at whether these new technologies and new solutions are indeed effective and making a difference in terms of health outcomes, about effectiveness and efficiency. We cannot do without our technology partners because as the world develop, the whole issue around being able to develop user-friendly, user-focused solutions, that is critical. And then topics around good data management, data governance, data security, we definitely need to work closely with our technology partners to make sure that our beneficiaries are protected. And then for applications and digital tools to work, we cannot do without partnering with mobile network operators. And all this work is ambitious, and we do need donor support. So alone, we may try to go fast, but definitely in cases like these, we need this multi-stakeholder collaboration in order to go together and go far. And in the midst of pandemic, what we're trying to figure out is how do we go together and go far while maintaining the physical distance that we need at this point. And it would be really interesting to also learn from the audience experience how you have done multi-stakeholder engagement during this really challenging time. Thank you very much. Thanks, Steve.
Great. Thank you very much, Miriam. Really appreciate it. Actually, we had just one question come in on the Q&A. The question is when is this, the community health worker application ready? When is it going to take off? And is this open source, and is it available for other organizations to use?
That is 5 questions in one. I will try. I'll try to tackle some of that. For us at the consortium, we actually right now hoping that in the next 1.5 years, we'll be able to build the prototype of the primary healthcare facility piece first. That is where the IMCI consultation and the CMAM outpatient treatment protocol is carried out. We'll prioritize that piece, and then we're looking at about like a 3 to 5 year time frame to expand and get a more complete suite of solutions. So yeah, getting funding for such an initiative is actually not easy. We've been trying to do the right thing rather than starting from scratch. We are trying to follow good digital development principles and integrating 2 strong existing tools. Unfortunately, the existing funding instruments tend to fund like starting from scratch pilots or scaled up. So for us, trying to integrate 2 strong existing solutions into something new and test that rigorously, it's actually not that easy to find funding. So we can get through this stage, then I think it will start to snowball, and we'll see a lot more traction and momentum. Yeah. So in terms of whether it is open source, we intend for it to become so. World Vision and Terre generally, we look at getting the Creative Commons license for our products. The intention is not to make profit out of it, but we would like to track how it's being shared and what modifications are being made to the solutions. And because this is really important to the whole digital health community, to try to find and develop and refine the most effective solutions. Yeah. So does that help? Thanks.
It absolutely does. Thank you so much. Really appreciate it, Miriam. We're going to move now to Ricardo. Ricardo and Miriam teed this up really well. We're talking about fragmentation, pilotitis, multiple applications, the burden on the health worker, and some of the challenges in partnerships. So in trying to reduce this fragmentation, could you really expand on how the AleDIA project is approaching this?
Yes, thanks, Steve. Good morning, good afternoon, good evening, everybody. So I have prepared a couple of slides. Yes, so now I can share my screen. So hope you see.
Good. Thank you.
Yeah, great. So yes, I would like to actually describe the example of e-DIAgnostic. Miriam described the 2 different protocols, the medical protocol and the malnutrition protocol. I would like to focus on the medical protocols and describe the experience of Terre. on which the consortium will build on and actually will also improve. So, here we go. So in 2010, Terre and the Ministry of Health of Burkina Faso co-created a job aid tool, which we call e-DIAgnostic, and which digitalized the medical protocol described by Miriam. And this medical protocol aimed to better diagnose and treat children that goes into the healthcare facilities. So the first step, so actually digitalizing the protocol, is actually the easiest part. And that was a picture of almost 10 years ago. Children going to the healthcare facilities. That you have the paper version. We created an algorithm, and then from the algorithm we put it on. At that time it was a PC. Now it's a tablet. And so the healthcare worker has a tablet on his hand, and which guides him or her across the different questions of the protocol. So that with the aim to increase adherence. Today, e-DIAgnostic is a rare example of digital solution at scale in sub-Saharan Africa. It's over 1,000 healthcare facilities are equipped with the tablets in Burkina Faso, which is 2/3 of the country. Over 60,000 users, so healthcare workers use the tablets with a percentage of adherence that goes over 90%. 2.8 million children are registered in the database, which is 15% of the total population of Burkina Faso, and 200,000 consultations per month are usually carried out. So in total, we have today over 6 million other consultations. So that is the power of when you go digitalize a protocol, you can rapidly go to big numbers. Today, e-DIAgnostic is deployed in Mali, just launched in Niger. We are in discussion to deploy it in India, in a state in India, and the MOH is taking over the control of this digital solution by end of 2020. So, so how come e-DIAgnostic was able to reach that level of scale? Because we see, as Miriam said, we tend to see more the pilotitis case rather than a solution that is a national scale. So definitely integration is a prerequisite to reduce fragmentation first, and then to go scale. So I will not spend a lot of time to discuss this picture, but it shows how integrated the solution is within the Burkina Faso's information health system. So it started with just the MCI, so on the center bottom, but then today the tool is much more than that. It includes also antenatal care, postnatal care, stock management. We have exciting dashboards, dynamic dashboards. So it is much more than that. And of course, it's integrated with the DHS too. But the integration is just a prerequisite, like it is interoperability. This is a must. This is where you actually have to start from. But to scaling up, and this is what the consortium will focus from when the consortium was actually built on, will be also on other key factors beyond integration, interoperability. And I like to refer to actually a study run by the London School of Hygiene and Tropical Medicine that was run a couple of years ago. And actually they produced 3 reports, and one of them is about why e-DIAgnostic was able to go to scale. And some of the reasons are, first of all, the MOH was on board from the very beginning. And this is crucial because Because just to give you an example, in most healthcare facilities, there is a paper version. So the healthcare workers are actually obliged to fill up the paper version of the protocol, unless it's the MOH that actually decides that you don't need to fill up the paper version any longer. Now there is this solution in place, and now you can actually just concentrate on the digital solution, which is actually a huge advantage, because actually you don't need to do the work twice. And also, as you know, digital comes with a lot of benefits. You need a long-term vision. It started in 2010. Miriam just said that the AleDIA time span for the full result would be about 3 to 5 years, which is a huge amount of time if you think of how quick IT goes. But then that would be probably just one another up. We need to think about the long-term vision. We need to think about tenacity. We don't need to give up. The e-DIAgnostic was changed 12 times until has changed for 12 times. And in 2014, actually, a donor came to us and say, you have an exciting tool. We are ready to actually invest much more on your tool, but then you need to start everything from the scratch. And that was actually was very tough to hear, but it also was the most precious advice, because that actually they told us how to build a robust platform about integration, about all other elements. And also the question about donors. You have donors that support you because it's innovative, or they support you because they're scaling up. But in the middle, who is actually supporting us? So we were very close for a couple of times to actually stop the project because this lack of funding. So I think tenacity is another aspect. Engagement by all stakeholders. So you can have a beautiful app, integrated long-term vision, but if you don't prove that this tool is actually useful by all stakeholders, the app will not be used. And then just as a reminder, the tool is left in the middle of nowhere, in a healthcare facility in the middle of nowhere, remote area. There is no Terre staff there. There's just the healthcare worker there that each time decides whether to use the tablet or not. And he or she will use it if he sees actually a benefit. And the benefit could be multiple things. So for example, the fact that once you enter all the data for running the consultation, which in any case you have to do it, but then you have all the data already in your database, and at the end of the month you don't need to actually spend hours and hours to do the monthly reports. So this is crucial, and of course the child caregivers, they need to be also engaged. Then medical relevance impact. If you want to go to scale, you need to show that actually what you created is actually relevant, medically, clinically relevant. And this is also why for the consortium, we will actually work hand in hand with the research institute. This for Terre, we were a sponsor actually gave us 1 million to run a 3 years evaluation on actually the effect of this project, which is actually is one of the rare cases also having such a large study for a digital solution. And the results, of course, were positive with a significant improvement of quality of care. And the cost, of course, you need to show that this is everything is beautiful, but what is the cost? And again, the report by the London School shows that actually there are some saving on the operating costs. And then finally, last but not least, partnerships. I think Miriam said it. If you want to go quickly, you go alone, but if you want to go far, you go together. So this is just the major partners that we work with. I mean, when you want to scale up, you want to have partners at operational level, research level, and of course those that could actually support. Finally, we go back to the alliance, to the consortium with the World Vision Action Against Hunger. So just to recap, that would be the aim is to reduce clinical fragmentations. As Miriam said, we have 2 medical protocols, but the patient journey is actually the same, especially in that part of the world where a malnourished child is also a sick child. And then the 3 levels of healthcare, other healthcare systems. Reduce digital fragmentation by having a pool of organizations together. De facto, you actually reduce the fragmentation because you have multiple players using the same data, the same tools, the same platform. So this is instead of having a bottom-up, a top-down approach. Actually, this is a bottom-up solution with a lot of benefits. And one of the benefits actually is there is an improvement in efficiency, in cost. The consortium now has to face a lot of questions, and I think they will come later in this webinar, like data protection, good principle of data management. So this is, I mean, these are expertise are very difficult to acquire. And if you are a consortium, I think you can benefit of some cost sharing. And then a few words on COVID-19. When you have integration, the solution is scale up. It definitely, this helps tremendously to address a crisis like the one that we're going through. If nothing has been done before, talking about integration is actually extremely difficult, because here it's a really hectic moment where everybody go really nuts. There is so many COVID-19 solutions already available. But if you have built this in the past, and this should be a lesson learned for the other countries that have not yet done. I'm not saying that it's easy, but it is definitely easier. And the picture that you see is actually the Burkina Faso map, and each dot actually shows at the moment how many clinical consultations take place in each healthcare facilities. But then because it's digital, because the data is all aggregated and in one single place, you can see lively, instead of the number of consultations, the suspected cases of COVID in that part of Burkina Faso. And so this is actually what Terre and other partners are working on in Burkina Faso. So with that, I give back the floor to Steve, and I thank you for listening.
Great, thank you very much, Ricardo. Really appreciate that. We've had another question come in on the Q&A, but I'm going to actually move that to our discussion at the end in the interest of time. So next I'd like to move to Marlies Gorgens from the World Bank. It would be great to get the funding partner perspective that you bring to this. We talked about long timelines, having to wait to see results, having to take the time to form partnerships. So it'd be great to hear from a funding partner perspective how you have seen this. Thank you.
Excellent. Thanks very much, Steve, and thanks to Miriam and Ricardo. I appreciate the opportunity to discuss with everyone some of the World Bank's perspectives on this. First, maybe just to note that, I think as a multilateral development bank, we see ourselves as both a technical and financial partner. And in that context, there are just 3 points that I would like to make. The first point is that I think there is definitely the opportunity and potential for these digital health solutions to really bring about a sea change in how we deliver healthcare. I think if there is a silver lining on the COVID-19 pandemic, it is that we've seen the proliferation and the rapid acceleration of digital health solutions. But for those solutions to work, we have to make sure that those solutions are integrated, that they are scaled, and that they're based on evidence of whether they make a difference. I think there is definitely the tendency for digital health solutions to be driven by those interested in technology and this underlying presumption that a technological solution is always a better solution. I'm not arguing, and I'm not arguing against digital health, just to be clear, but I think it is fundamental that we have metrics of what does success look like. The bank has been long interested in this AleDIA program because it does what we think is so fundamental, and that is, which is closing off the first point that I wanted to make, that it provides an integrated digital health solution. In other words, it moves us from letting 1,000 flowers bloom in the digital health environment to an integrated, structured, scaled solution, which is absolutely fundamental. Now, a few, and Miriam mentioned the challenges of funding. We actually hope to be co-financing the creation of this AleDIA initiative, because I think that if there, to me, I understand that there can be funding challenges, but I also think that if there are good solutions, we'll find the funding, right? I think what is actually more challenging, what we found, is not the funding side, but is in getting these different digital health solution providers to work together, which again is where I think this notion to come together and to create a consortium is such a powerful lever of change, because we often see individual digital health providers kind of competing against each other. My solution is better, no, my solution is better, instead of coming together and taking the best of all these solutions and creating things that work for people, creating things that work for healthcare providers, and creating things that work for the administration of healthcare systems. The second point that I want to raise is around the use of artificial intelligence. I actually think in the healthcare space, we need to talk about augmented intelligence, because we never envisage machines or computers providing healthcare on their own. We always see them as being a support to the healthcare system. And again, it's a conversation I've long had with the team at AleDIA, is it's this challenge when we scale a digital health solution, because most of our current digital health solutions don't have AI necessarily embedded in them, right? Think, for example, of a community health worker app. They don't yet, in an automated way, in a predictive way, cluster and prioritize households based on key characteristics and based on the outcomes that we know of other similar households, right? And they don't prioritize where community health workers should go based on that in a predictive way. And part of the challenges of digital health solutions is, do we scale first and then we embed AI to make it better? How do we use these 6 million records in a way that is privacy preserving, right? I think that's the challenge, and that's something that every set of solutions will have to figure out. I think we would argue that what we've seen work is to focus on both, to focus on scale, but also on how we're going to make the system more personalized, more predictive, more relevant to the populations themselves. The third and last point that I want to make is on the issue of data protection and data privacy, because I think that is absolutely fundamental. We have to make sure that we get governments to develop the regulations, to create the data governance structures, to have data stewards that are independent and that make decisions about how data gets used, how it cannot be used, ensuring that these applications are privacy preserving, which is possible and feasible to do. But we have to make sure, and this is particularly important in COVID, where we see a lot of applications now coming to the fore on digital contact tracing. How do we make sure that those applications are privacy preserving in a way that we don't create these national individual location-based surveillance systems? And for that, good regulation are needed, and smart regulation that we can adapt as the need arises. Thank you very much, Steve. I hope that was useful.
Great. Thank you so much, Marlies. Really appreciate that perspective. And you touched on the use of artificial intelligence and augmented intelligence, which has been really a hot topic for some time now in the development sector. So I'd like to turn it over now to Claudia. You've been working the private sector with the cloud era, where AI and big data is really transforming the way that we manage and use information. So it'd be great to hear your perspective on how the AI and big data is really being used in an initiative like AleDIA. Thank you. I'll pull up your slides here. One moment.
Thank you, Steve. And hello, everyone. Good morning, good afternoon, good evening, wherever you are. Steve is pulling up the slides. Thank you, Steve, so much for that. And we can directly go to slide number 2 to get us started. Kind of a small point of clarification. You said I'm working with the private sector, and just to be clear, I'm not employed by the private sector. The Cloudera Foundation was created by Cloudera, the company, an enterprise data cloud company, in 2017. But we are actually a private foundation and an accredited 501c3, so nonprofit organization in the United States. We use private sector tools and expertise to assist and build the capacity of nonprofits to use data analytics and data technology, but we are not in the business of selling software. Moving on to the next slide, which is a little bit calmer. I don't know why kind of it moved around in the previous one. So clearly my comments are really coming from the perspective of someone that works with nonprofit data. How can we assist nonprofits to use data analytics and data technology? And coming back to the question, where do I see the potential of an alliance such as AleDIA? And Steve, just checking, my screen is flickering. Is that happening to everybody else? Should we find a different way to?
Unfortunately, it seems to be on my end. So if you can run the slides, that's fine. Unfortunately, it is something that's happening with.
Let me see if I can share my screen. Then you would need to stop sharing, and then I'll pull up my slides.
Great, go ahead. Sorry about that.
Okay. No problem.
It's always fun to introduce some technology challenges midway.
This is what life is these days. Can you see my screen now?
Yes, we sure can, and it's not flickering. So thank you.
Okay, perfect. Well, thanks so much. Well, I'm just getting started, so you haven't really missed or significantly been distracted by anything. I was just saying I'm really commenting on AleDIA and the alliance between Action Against Hunger, World Vision, and Terre from a data perspective. And a lot of the promise of the use of data, more data is being available. We have increased capacity to analyze data. Is based on the use of what at some point we called unconventional data sources. That was originally defined as exhaust data, so data that was generated as a byproduct by some other process. So for example, it could be cell phone data, so call data records are obviously not created to provide geolocation like it's being discussed to be used for contact tracing and COVID-19. Drought data is not necessarily to produce to inform more nutrition, but we are using these additional data sets, and we have that ability to use these additional data sets to either fill in gaps where we don't have very frequent information or to kind of complement and enrich our understanding of specific problems. But clearly, when you think about it, it is preferable to use data sets that were specifically collected with a purpose in mind and that respond to a clear problem definition. And so when I go to the next slide, and I can't agree more with what Marilise was saying. I mean, is AI a tool looking for a cause, or is AI a solution? Yes, the AI is a multi-purpose solution, or data, the use of data, the more sophisticated use is a kind of a generalizable or a general tool. And it is still required that we clearly define what the problem is, and how, whether it's even AI, because I agree that in most cases we don't really see AI, we see more sophisticated data use. What is it really contributing to the solution, and is the effort that it is entailed worth what it brings to the table? But in the case of AleDIA, what is really the benefit is that by harmonizing those two different protocols, IMCI and CMAM, it creates from the step of intake to the analysis of the data and the use of data by the Ministry of Health an improved patient and health work experience and improved potential for data analysis and use. When we have a lot of conversations about the use of standards, and standards are clearly very important in the digital health space. Standards facilitate the exchange of data across geographies and verticals, such as what we are dealing with here, children's diseases and nutrition. But the use of that aggregated data by using standards will still require more efforts and leads to a higher probability of errors than if you have a really fully integrated approach like AleDIA is looking at across all the stages of the data lifecycle. I think Miriam and others already also spoke to that this also increases the potential and the ability to generate new knowledge from the data across a patient's journey, and leading to the refinement of treatment protocols and shedding light on risk factors, etc. One thing I think that Ricardo already highlighted to some extent is, so what's the benefit of scale? I think one thing that is truly remarkable about the e-DIAgnostic project is that even though we talk about scale, I find all the time when it comes to digital health, this is one of the largest digital health projects on the African continent. And so it's more now than 6 million consultations. It's really growing very quickly. And that means it's really at the scale where you have the data volume that you need to really use it in a sophisticated way for predictive and machine learning uses. Because I think that's a problem in many cases, that the numbers are simply too small. And here we are kind of reaching a point where it is really getting to a level that allows for those sophisticated tools to be utilized. I think we already heard something about economies of scale. Miriam had that great picture about the multiple devices that health workers are juggling with. It's a question also of training, but Ricardo also spoke to the data-related expenses. So what is the ability of nonprofits and implementation organizations to build up the internal capacity to have, let's say, multiple data scientists, a data engineer, and others on staff. So it's really using constrained resources most effectively. And maybe the additional benefit could also be that it pares down some of the redundant monitoring and reporting activities that bog down many nonprofits as well. The last point that I want to make, and that is, I think, what's particularly relevant to the crisis that we are seeing right now, COVID-19. And we have seen that in kind of past crises, whether it's HIV or Ebola, that we have clearly a tendency to focus on the emergency at hand. But we need to make sure that in light of the system level shocks that we have seen previously, that we make the system more resilient to an array of unknown shocks and stresses instead of waiting until the next crisis to focus on a specific health issue. And so integrating across different verticals is clearly the way to go. An additional benefit is also that there's clearly related to the misdiagnosis, already happening misdiagnosis of malaria and the increased risk because of underlying conditions. It is important that we kind of start integrating COVID diagnosis and treatment into existing solutions. From a data perspective, and Mari-Lise was talking about that, and Steve, you also hinted at that in your introduction, it is often easier to stand something new up quickly because it doesn't require as much thought about interoperability and integration. And we have seen, I feel, a significant number of failed efforts in that regard over the past years. But building on existing platforms such as AleDIA and e-DIA in this particular case will allow to benefit from data governance and security efforts that are already in place and that are often not as much in focus in emergency responses. So building on existing solutions where data protection by default is built in is clearly the way to go. And lastly, and that is also building on how can these tools be used for predictive analytics, looking at this really in a conjoint way allows the Ministry of Health to gain a fuller picture, learning on health trends, including those for epidemics, looking at what's the relation between post-COVID and malnutrition and trends and trajectories of childhood infections. I mean, those are some of the benefits that we are seeing from a collaboration such as AleDIA. I think one point that I want to emphasize is that I've been in philanthropy for about 15 years. I think this is one of the very few collaborations that I have seen where nonprofits have chosen to come together to align their programs on their own, rather than responding to kind of an incentive set by donors. And I think that is a very powerful thing. Different from Mari-Lise in kind of sharing this with a couple of my colleagues in philanthropy, I've heard a lot of questions around, isn't this the most cost-effective way from a collaboration perspective? So people in philanthropy and donors were worried about what are kind of the additional costs of the collaboration of these organizations to come together. And yes, I think this will require more time to govern, but I truly believe that the results and the additional efficiency this can generate in the field is very well worth it. And with that, thank you for listening and looking forward to your questions.
Great, thank you very much. We're coming up near the top of the hour here, so we do just have a short bit of time for questions, but did have a couple questions that came in. Talk about working with the Ministry of Health, and we'd like to hear more about the plans to, or if the systems are being handed over to the Ministry of Health, or what the plans are for sustainability to work with the Ministry of Health to have them take this on going forward. That's Ricardo or Miriam.
Yeah. So if I understood correctly, because the line was not well, I mean, if we have discuss that with the MOH in the country where we like to develop the solution, correct?
Yes, and how things would be moving to have them take on.
Yeah. So I think, I mean, as I said earlier on, having the MOH from the very beginning is one of the key lessons learned that we had in Burkina Faso for e-DIAgnostic. So when we convened the three organizations together more than 2 years ago, we actually see that we saw that as a key element in order to actually advance. So we had a workshop in Senegal, in Dakar, because it's where we would like to actually develop the solution. So a solution that covers the needs of the West African countries to start with. So we had a workshop which brought together MOH staff, TDH, World Vision, and Action Against Hunger staff to discuss together about the initiative, whether it was first of all that whether would tackle the needs, of course, to start with, but would that be something that the MOH would buy in and support. So that was actually all the preparatory work that we've done. And now we identify to start with would be Mali. And in Mali, we started the discussions with the MOH. We increased the discussion with the MOH to pave the way to the kickoff of this technical solution. Miriam, would you like to add anything from your side?
I think you summed it up really nicely. Thank you, Ricardo.
Great, thank you. Another question that's come in, and just for those who have to leave right at the top of the hour here, we will of course make this recording and the slides available through the Global Digital Health Network website. So please feel free to access. We'll also try to share answers to the questions that we don't have time to get to. We'll take just one question more, and this could be for any members of the consortium. You've highlighted the partnerships and the impressive number of partners that are in this consortium. Is the consortium actually open to bringing in any additional partners during this phase?
So the consortium was launched 2 years ago, and there are 3 funding organizations: Action Against Hunger, World Vision, and Terre. But as I said from my presentation, the importance to actually have multiple partners or different type of partner is actually essential. So I think there are no closed doors to anybody. On the contrary, we will actually consider including other organizations. I have to say that this is not just a simple consortium that we often see. When we started, actually, we spent multiple hours to look at the governance of this consortium. So we also established a governance to ensure that there is that we cover aspects like the geographical share, the lead in, for example, in an aspect like fundraising in one country. So actually, this has been everything was actually discussed beforehand, so that any other partner would need to be integrated into this framework. Miriam, would you like to add anything to that?
Yeah, it's actually a very great experience trying to figure out how we work together, and so far it's been just really positive. So there are different aspects, such as, if we are going after a funding opportunity, there's like consensus around, which organization is best positioned to take the lead. Yeah, so the door to new partners is definitely open. And usually we go through like a consensus process to look at when is a opportunist, like when is a good time, you know, in terms of like the journey of an initiative to include new partners, the processes of, you know, coming to consensus and things like that. So it's a positive experience, and you know, we learn a lot through that. So the door is not closed, and yeah, so the conversations to be had. Thanks.
Great. Thank you very much. I really appreciate everyone taking the time to attend, and thank you so much for the great presentations and being willing to put up with a few audiovisual challenges. Like I said, the materials will be available through the Global Digital Health Network, and we will include the Q&A as well as some answers to the questions we didn't get a chance to take. Before people leave, we did want to ask people to take a short poll just to provide feedback on the presentation. But I'd really like to give a virtual clap, round of applause to all the presenters and the great work that's being undertaken here around child health, childhood illness, malnutrition, and COVID. So thank you very much. Really appreciate everyone's time. Have a great day.
Thank you.
Thank you, everybody.
Stay safe.
Thanks, Steve.
Thank you, Steve.